Today we're going to talk about tendinitis versus tendinosis. As we start, I'd like to acknowledge the generous help of Dr. Cornelia Kulig, who you see here on this picture. She's got a number of honors and positions, but she's also one of the most wonderful people that I've ever met. So if you have a chance to go to any of her courses or meet her, perhaps at the Combined Sections meeting, please take advantage of that. So first, a lot of things are described as tendinitis, or for example, plantar fasciitis, and they're really similar types of problems. And what I think you'll understand after this talk, if you don't understand this already, is that expression tendinitis, plantar fasciitis, is overused a lot and used to describe problems where it really isn't a problem of inflammation. Remember that when you see that suffix itis, what that expression is saying to you is that the problem is inflammation. Now, inflammation has gotten a really bad rap, I think, over the past several years. But inflammation, when it takes place such as it should, is the body's way of healing itself. So it's a very important process. If we did not have inflammation, then every cut that we ever had since infancy would still be on our body. So inflammation begins with the inflammatory phase, which is an immigration of white blood cells and several different types of white blood cells. And as those white blood cells die, and it's called apoptosis, which is programmed cell death that is supposed to happen, they secrete inflammatory chemicals, including histamine, cytokinins, and nitric oxide. Those chemicals cause the next phase of inflammation, which is the proliferative phase, which starts with angiogenesis, the development of granulation tissue, which is just the presence of microcirculation to support the fibroplasia. Fibroplasia is the beginning of the formation of collagen, which starts 2 to 5 days after original injury. During the previous phase, as we've discussed in a few classes over the past couple of years, the collagen is remodeled. The collagen, when initially deposited, is soft, pliable type 3 collagen, and it is remodeled through arthrokinematic and osteokinematic motion. After 5 to 9 weeks, the fibroblasts begin to die. Again, this is, as it proceeds in its normal sequence, a process of apoptosis. The death of those fibrocytes give off certain chemicals that cause the cross-linking between collagen fibrils, which is what you see in the diagram on the lower right side of this slide. And it is a cross-linking of those collagen fibrils that turn soft, pliable type 2 and type 3 collagen into the very tensely strong type 1 collagen. And that cell death of the fibroblasts, most of them die and give off these chemicals. Some of them will mature into fibrocytes, but most of them die. It is that which allows the now type 3 collagen with those chemical cross-links to be the very tensely strong, mature type 1 collagen. So indeed, if a person has true tendinitis, then the pain that they're perceiving in the tendon or perhaps the plantar fascia is indeed from inflammation. However, inflammation isn't the only thing that can cause tendon or fascia pain. Frequently, under certain conditions, which we'll talk about over the past several minutes, the problem is what we describe as tendinosis. And tendinosis is a more common type of tendinopathy and is recognized as a degenerative process. So biopsy tissue samples or tissue samples from animal modeling have revealed differences between the actual tendon tissue in the process of tendinitis or the process of tendinosis. Tendinosis leaves tissues that are characterized by an increased cross-sectional area because of increased ground substance and hypercellularity and increased vascularity, disruption of the mature or type 1 collagen fibrils, an increased proportion of the more soft elastic type 2 and type 3 collagen fibrils, and the mechanical result is decreased tensile stiffness, or that is also to say increased plastic deformability, which is exactly what you don't want from a tissue like a tendon. Being able to diagnose the difference between tendinitis and tendinosis is really important because the two conditions are treated differently. Now, the slide that you see here is actually the work of Dr. Kulig, and it's reproduced here by her express written permission. So one of the first things that you think about in making the differential diagnosis is the history. If a problem is occurring for the first time, then it's more likely to be a tendinitis. But if the problem is recurrent, that it's been on and off perhaps for years so far as the symptoms, then it's much more likely a tendinosis. If it's preceded by an uncommon activity, for instance, you're working with a runner with plantar fascia or Achilles tendon pain, and that individual just went from running an average of 9 miles a week to 15 miles a week, so that's a considerable increase, and then the pain started, then it's more likely a tendinitis. If, on the other hand, that a runner has had that pain on and off, and it started for no apparent reason, they are still running the same 9 miles a week, such as they have for the past several months, then the problem is more likely a tendinosis. If swelling or warmth or those other observable symptoms of inflammation are present, then the problem is more likely tendinitis. If they're absent, then they're more likely a tendinosis. Be careful to distinguish between swelling or nodules, because nodules are actually really common in cases of tendinosis, and that might be in the Achilles tendon especially, or in the plantar fascia. Remember, we were talking about this in the last slide, that those nodules are most likely the observable result of increased ground substance and increased vascularity. If the problem is responding to anti-inflammatory medication, which is frequently off the shelf, then the problem likely is tendinitis. So the positive response to anti-inflammatory medication can actually be diagnostic in this case. If it is corroborated with imaging, and the type of imaging that is best for distinguishing the difference is ultrasound. So if a diagnostic ultrasound shows increased ground substance and increased tendon girth, then your problem is probably tendinosis. Tendinitis does not look any different on ultrasound compared to a healthy tendon. One more factor is the age. So people my age, or even a little bit younger, but definitely older than you, 30 years or older, are more likely to have tendinosis as compared to tendinitis. So when you're seeing a patient, really important to put all these puzzle pieces together because the treatment is different. This treatment idea, which we are going to describe, is also developed by Dr. Kulig and called EduRep. So the first part is educating the patient about which type of problem they have and what to expect, then unloading to the appropriate amount. You unload, and we'll talk about this more over the course of the next few minutes, but you unload a tendinitis to the extent where there are no symptoms. You probably want to relatively unload a tendinosis, perhaps from what the person is doing, perhaps not. But symptoms aren't as important to pay attention with a tendinosis compared to a tendinitis. then with both of these problems, you reload them in a very careful and prescriptive way, and then continue with the type of exercises which are eccentric exercises and sometimes even high velocity eccentric exercises to make those tissues really robust and help prevent recurrence of injury. So in general, with tendinosis, you would educate the patient that the problem is not inflammation, despite what they have heard, with perhaps the ideas that we had described before, that inflammation over the past couple of generations have been getting a really bad rap. Actually, I think, and this is just my hypothesis, that what is going on in these cases is that the inflammation is arrested instead of continuing to the maturation phase and the remodeling phase, that it stays in the proliferative phase. But anyway, one more thing that you need to educate your patients with a tendinosis type problem is that pain, or the lack of pain, is not really a good indicator of tissue impairment. Now, this is a pretty positive thing if you're working with older runners or other exercisers, because generally they're actually pretty aggressive about their exercise, and the idea of having to stop would make them unhappy. Common treatments like non-steroidal anti-inflammatories may actually prolong their morbidity, because what you want to happen actually is the inflammation to progress. And again, educate them that just because the pain has resolved, that doesn't mean that they don't still have that tissue weakness characteristic of tendinosis. So they'll need to work on the reloading for months in order to really improve the tissue characteristics enough that they can be reasonably confident that the problem won't recur. Unloading would be decreasing the dosage of the offending activity. For instance, if your patient is a runner, have them decrease the dosage, but not necessarily completely stop running. One of the ways that you can also unload is through a damping surface. We've talked about that a lot over this semester, and hopefully you can think of the ways that will help in decreasing the length of the external moment arm, as there is a smaller joint flexion angles that the patients will have doing the activity on a damping surface, and also decreasing the speed of the eccentric loading. Adjustment of kinematics is something that is really important, and we'll talk about in more detail in a minute or two, that can help decrease moment arms and therefore decrease the load on the joints and the tendons through many activities. And also you may think about assistive devices or supplies to help unload the involved tissues, such as orthotics, heel lifts, or taping. When you reload a tendon injury, please consider the type of muscle activity, because the muscle tendon tensions vary depending upon what type of muscle activation is going on. So remember that the concentric, especially the fast concentric, is the type of muscle activation that will yield the lowest muscle tendon tension, followed by slow concentric, followed by isometric, followed by slow eccentric, and then the highest tension activity are the rapid eccentric loading activities. Another progression that you should think about is the manipulation of the surface. So remember, what you would start out with is a damping surface, so that the surface is helping the muscles and tendons of the patient absorb some of the energy. So here we see, for example, a patient who is landing on a foam pad or a very damping surface. Here we see a patient who is landing on a hard floor but wearing shoes, and the shoes can help absorb some of the force. And then finally, a patient who is landing on a hard surface with bare feet. This type of activity would be reserved for the end of rehabilitation when the tissues are absolutely the most robust. And then the prevention would be carefully dosed rapid eccentric muscle activation, because as we've talked about throughout the semester, that is a type of activity that can best cause the adaptations that make muscles and tendons most robust against injury. This set of photos represents what we mean by kinematic adjustment. So the woman over on the left side is doing a jumping activity, but you see that her trunk is rather vertical. Therefore, she's got a smaller external hip flexion moment and a larger external knee flexion moment. This would be exactly what we don't need if the person's problem was, for example, patellar tendonitis. So the fellow over on the right side has more of an anterior pelvic tilt and is inclined more forward with his trunk, and therefore more effectively distributing the external torque between the knees and the hips. This slide has a lot of text on it, and you can read as well as I can, but I do want to describe a couple of the important things that this is saying. First of all, what this is saying is that tendons or tissues that are thickest or the hardest to load will need the highest dosage of eccentric loading in order to make the effect. So, for example, you'll need to load the Achilles tendon more frequently and load it harder than you would need to load the tendon of the supraspinatus. Now, again, the mechanism through which the eccentric loading helps with this problem is rather speculative, but my idea is that through the eccentric loading, especially high velocity eccentric loading, we're able to destroy some of the fibroblasts which are hanging around. And we need the chemicals that are released through the death of those fibroblasts in order to bring about the maturation of the tissues. This perhaps is also the mechanism of effectiveness of some of the really deep, vigorous tool facilitated massage techniques, which also can treat problems like tendinosis. Like, for instance, you may have heard of the Graston technique or of A-stem. Those are massage techniques in which we massage muscles or especially tendons with these tools, probably also destroying fibroblasts and releasing those chemicals that can bring about maturation of the collagen. As we mentioned a little earlier in this talk, the treatment of tendonitis is a bit different. In the cases of tendonitis, the problem really is due to inflammation, although it can progress to a tendinosis type problem if it isn't resolved early enough. Now, with tendonitis, what you want to do is really respect the symptoms, because unlike the problem and the treatment with tendinosis, if you have pain with an activity, that is actually going to delay the recovery. So you use whatever amount of unloading that you need to and whatever assistive devices or supplies that you need to allow the patient to navigate through his or her day without pain. For example, a few years ago, I was working with a very young woman who was a runner and had a problem with Achilles tendonitis. And indeed, we were able to discern that the problem was tendonitis. So one of my prescriptions was for her, when she was going through her school day, to wear some cute wedges. Of course, I don't know whether or not they're cute, but she was able to discern what was cute. Anyway, the important thing is by externally lifting her heel, we're decreasing the external dorsiflexion moment, therefore also decreasing the demand of internal plantar flexion moment, and thereby decreasing the load on the Achilles tendon. So the reloading would be in the same order as tendinosis. The good thing about treating the tendinitis. On the one hand, it perhaps takes more discipline because you need to really listen to your body and not do anything that causes the symptoms and unload to the extent that the person is symptom-free. But the good news is that treated correctly, the morbidity period, the time through which the patient has a pain and disability is much less than it is with tendinosis. What is demonstrated here is just an example of what I was just describing in the previous slide. So if you have flat shoes, then with day-to-day activities, the external dorsiflexion moment is higher because you see that the ankle is going to go through a greater excursion. And therefore, what you may want to do with people whose problem is Achilles tendonitis is increase the heel height, perhaps not quite as much as you see in this picture on the right, but somewhat, and that'll decrease the external dorsiflexion moment and thereby decrease also the internal plantar flexion moment that is needed to control it. However, this type of footwear is exactly what you would not want with a patient with a patellofemoral or including patellar tendonitis problem, because that increased heel height also increases the external knee flexion moment by tilting the tibia forward. Okay, and here are some guiding factors to help you make that diagnosis and effectively treat patients with this type of problem.